My name is Emma. I am a physical therapist. I work at Zion Physical Therapy in New York City. So we have different locations throughout the area, and I work in the one that's on the Upper West Side. I specialize in pelvic floor physical therapy, but I'm also doing just the traditional orthopedics where somebody comes in, their shoulder hurts, their knee hurts. So I'm addressing those types of things. But in the pelvic floor world, I'm also working with different things that involve the pelvic floor, whether that's bowel bladder changes, pregnancy, postpartum. And a lot of that does kind of overlap with some of the things that we're talking about in relationship to like what are some things to expect happening at the pelvic floor, especially when that's involving something of like a chemotherapy and radiation. So I do have something to present. Okay, but we can get into this. So I just wanted to put a little bit of a brief overview of some things to expect post chemotherapy and radiation, with also just a little bit of introduction on what the pelvic floor actually is. So, perfect. So I just wanted to talk a little bit about some of the changes that happen. So this could be, again, daily comfort and function, controlling bowel and bladder, intimacy and relationship pieces, and then just overall quality of life. So a lot of the things, some changes that you might notice in your body, they come up, but a lot of the times we're not talking about it. Things aren't normalized. So I just want to start bringing a dialogue to this and talk about some things to expect, and also how even getting some specialized treatment at pelvic floor physical therapy, if there's anything that's kind of resonating with you, there are some things that we actually can work together and start helping to make a positive difference. So, starting with the pelvic floor anatomy and function. So, I always like to just explain the pelvic floor as almost like a hammock-like structure that's sitting at the base of the pelvis. So, I have my trusty pelvis, if you can still see me here. So, we have where the spine is coming down into the pelvis. And then at the bottom, if you're looking down, up and in, that's like this first picture up on the left. These are the pelvic floor muscles. So again, our bladder, the uterus, the rectum, all of those things are sitting here inside this pelvic bowl. And it plays a role in bowel and bladder function, sexual function, and sensation. So when we're thinking about how this fits in with the body as a whole, the pelvic floor essentially starts in the base of the pelvis. That's kind of looking at almost like that pelvic diaphragm. And then we also have the breathing diaphragm that we're thinking of that lives in the rib cage. So when we are breathing, those things actually move together, and it helps to manage our intra-abdominal pressure. So when we breathe in, both the diaphragm and the pelvic floor are going to lengthen and descend. And when we exhale, they move up together. So I think of both the diaphragm and the pelvic floor moving with one another. So whenever we're thinking of certain activities and movements that we're doing that are changing our intra-abdominal pressure, likely the pelvic floor is also working within that picture as well. The pelvic floor is also essential in how we're working on our overall stability, and just thinking in terms of proximity, right? We're in the pelvis. This is working so close with our hip muscles, our lumbar spine, and our abdominal. So all together, whenever people are talking about the pelvic floor, I'm essentially thinking of everything from here down and then from the knee up. A lot of that is what I'm addressing. With the pelvic floor as well, it's also important that we have a pelvic floor that can be both strong and flexible. So it's important to make sure that we don't want something that is too tight where it's not able to withstand the demands of running, for example, or going up and down stairs for walking, right? We need the pelvic floor to be able to move. But on the other end of that spectrum, we also don't want a pelvic floor that's not quite strong enough to help stay contracted when we're maintaining urethral closure and making sure that we're not having any kind of leakage or incontinence there. So it's always like that idea of Goldilocks, of finding that balance in between, where a lot of the functions that we're doing in life, we need both strength and mobility. So a little bit about what it is that I do in pelvic floor physical therapy. I think when people think of physical therapy, they think of the traditional, let's go and exercise and my knee hurts and we'll do all of these things. And pelvic floor physical therapy is a little bit more of that niche. And I think people always have a little bit of wonder as to like, well, what is it that we're actually going to do? So essentially, because the pelvic floor are still muscles, we want to make sure that the muscle tone is appropriate for the types of things we want to do. A lot of the time I'm working through different pain management strategies. Maybe it's helping to improve bowel and bladder function, sexual function, and then just begin to have these important conversations of just teaching ourselves about our bodies a little bit more. And then some ways that we're kind of getting into that is maybe we'll do some manual therapy. So this could be in any type of like external structures. Maybe it's glutes, maybe we're doing abdomen. We can also do manual therapy at the level of the pelvic floor. So sometimes that can be like external pelvic floor, whether it's on like the external labia, or we also can be doing some manual therapy with the internal pieces of the pelvic floor. A lot of that is, again, like breathing and posture, relaxation and strengthening, again, going back to that balance, and just talking a lot about how this is playing into the typical things we do day to day. When we're talking about pelvic floor dysfunction, so what that might look like is something that's hypertonic or overactive, hypotonic, underactive, or a little bit of mixed. So we can have that balance between there. So some things that could be is pelvic pain, difficulty bowel bladder, painful sex, or any kind of urgency, whether that's like urinary urgency or fecal. If something is underactive and not working enough, that can be something like changes in sensation. We might be having some leakage or any feelings of heaviness or descent in the vaginal area. And then sometimes, and most people are falling somewhere within that mix of helping to manage muscles that are doing too much and ones that we want to start bringing into the party a little bit more. So some of these, like 5 main areas to consider during recovery with chemotherapy and radiation, these are each of those pieces that I'm going to dive a little bit deeper into. So first to start is looking at some bladder and bowel change radiation, like it could be on a specific area of the tissue that's going to change the integrity of the tissue. And so then it's going to function a little bit differently. So some things that might happen is there could be urinary urgency and frequency, any kind of leakage, or changes in the actual like bowel consistency. So what I'm working on, and some things that we can talk about from there, is how do we work on the coordination of the pelvic floor? I think when people think about exercising of the pelvic floor, they're thinking, oh, this is just going to fall into Kegels, or let's just do a contract and relax. But at the end of the day, sometimes not every person is going to benefit from doing that type of specific strengthening. We want to make sure that the pelvic floor is coordinated, where when we want the pelvic floor to contract, it contracts. And when we want it to relax, it relaxes. Sometimes if we're dealing with more of the constipation side of things, and I'm doing the pelvic floor assessment, is I want to make sure that the output of when we're trying to bear down to have a bowel movement, that the pelvic floor is lengthening and relaxing to allow for the stool to pass, versus we're bearing down, but we're actually contracting. And then that's going to make it harder for something to exit, right? So that's looking a little bit more into that coordination training. And then we can talk about the actual habit retraining. So if somebody has increased urinary urgency and you need to urinate more frequently, there are actually some specific techniques that we can do called urge suppression drills that allow us to buy some more time when we have the urge to then make it to the bathroom a little bit more effectively. So this is kind of what I was talking about, the dyssynergia. So what that is making sure that the coordination of the pelvic floor is appropriate to allow for the stool to pass. And so sometimes if I'm asking somebody to bear down and they're contracting, is we spend a lot of time being like, how do I use that intra-abdominal pressure to our advantage, right? That's what we were talking about, of managing with the diaphragm and the pelvic floor, but make sure that we're doing it in a way that's still safe for the body, rather than doing any kind of strain where we're holding our breath and really bearing down. So that kind of goes into the piece here, and how pelvic floor training helps is we can make sure that the pressure management and breathing is working in our best interest. Another piece that could be expected is the changing in the tissue and how that then is relating to the way that sensation is feeling. So that could be something of increasing pelvic pain. Maybe the tissue just feels tighter. It feels a little bit less flexible. Maybe there's burning or aching, maybe abdominal pain. So if there is any of those sensitivities to those areas, this is when we're then tying in how some manual therapy and maybe some tissue mobility work can be really helpful. So I like to use the analogy of, if, for example, let's say somebody runs a marathon and they're like, wow, I'm having some tightness in my calf muscle, right? So every time that we touch the calf muscle, they're like, wow, that's pretty painful and sore to the touch. What we typically want to do in that point is do a little bit of some gentle massage to get that tissue to be a little bit more pliable. And so then it can function and help with the next time they want to go walking or do another marathon. If the tissue is changing, and now we're talking about in the pelvic floor, even doing some just gentle massage helps to introduce a little bit more pliability into those structures. And on top of that, when we start cueing in some guided relaxation, this is when we then cue in our nervous system. So the nervous system, we have the piece that is our fight or flight, and we also have the piece that is our rest and digest. A lot of the time, if we're having pain or cramping and things feel different, our body tends to want to contract to in as like a safety mechanism, because right, we're responding to something that's a painful stimulus, but also how much of that contraction is also in like a cycle kind of feeding into some of the pain that we're having. So when we pull in that relaxation, that helps us grab that piece of the nervous system of that rest and digest, where we then can then get a little bit more of that releasing through the pelvic floor. And a combination of all of these things over time is helpful in managing with some of the pain. I also spend a lot of time talking about sexual health and intimacy. And so some things that might come up would be pain with penetration, any change in the actual lubrication of the vaginal area, changes in arousal, decreased libido. And when there is any of that pain, one thing, if that fits appropriate with everything that we're finding in the examination, is something called vaginal dilators. And essentially what this is, I think I have a picture on the next slide. Yes. So if you're looking in the picture on the left, there are a bunch of different tools and gadgets and things that actually help with almost that like graded exposure if there is that pain with penetration. So for example, if I'm doing the examination with somebody, when I'm doing the exam, I'm using my index finger. Sometimes if me doing the assessment of like internal or external at the pelvic floor is painful with that, I can't really shrink my finger. So sometimes if we're wanting to get back to those goals of like feeling more comfortable during intercourse, having less pain, this is kind of one of those close ways to simulate how the body's responding to things of different width, but also length. So these are the multicolored ones that they kind of look like the graduated cylinders. The teal one on the top that looks like almost this squiggle, I guess. So that is a pelvic wand. And what that does is it actually gets a little bit more of localized pressure to different parts of the pelvic floor. So you can see that there's like that tapered end and then the small thin end at the top. Both of those ends, one or another, depending on what we're working on, can be inserted into the vaginal canal. And if somebody is saying like, oh, like I'm having some pain during intercourse, but I feel like it's deeper into the vaginal area and it's kind of in like one spot, likely we're going to be working with the pelvic wand to do a little bit of that targeted release. Some recommendations that I have for different lubes, if the vaginal dryness is something that's also what you're experiencing. So these are two brands that I recommend and even have samples of in my office that I'll hand out to patients. So the one on the left the Good Clean Love, that is a moisturizing vaginal gel. So that could be something that you use even throughout the day. It also works as a lubricant for intercourse. But sometimes if there is any dryness or maybe itching or irritation with wearing underwear, sometimes adding a little bit of that extra moisturization, just like you would moisturize your hands when your hands are a little bit drier, that's something that could be helpful there. The one on the right, Uberlube, so that is a silicone-based lubricant, which also is something that can be useful during intercourse. When I am using the dilators or the pelvic wand with patients, and they're also doing that at home, those instruments don't pair well with the silicone-based lube, so that's the one on the right. So usually a water-based lube is what I'm recommending for patients when they're using the wand or the dilators. But then if they wanted to use that other lube or they realized that they liked it, then that would work best during intercourse.
How soon post radiation is the best time to begin pelvic therapy? And is there a best time?
Okay, great question. Usually that I'm seeing people maybe probably around like post that 6 week mark is usually when, even if there's like any kind of a surgery or operation, or like even if somebody's delivering a baby, usually I'm seeing people at least 6 weeks out. A lot of the time though, I do always just recommend that off to the extent of the person who's doing the radiation or the oncologist on making that recommendation on what they feel fits best with that. And then that also could be a question for OBGYN. If they feel like for whatever reason there was more things of navigating that it would be appropriate to wait for more time, usually I'm seeing people around that 6 week mark, but I would always just ask them to have a little bit more of a specific guidance just if there are other pieces of the puzzle. Did that kind of answer the question there?
Yeah, I wanted to ask too really quick, Dr. Emma, is what about scar tissue? Is like some of the tightness, does it have to do with scar tissue and kind of breaking that down, and does that ever like go away completely?
So that it is a great piece to also add in as well. So whenever I'm thinking of like tissue in general, I always think of tissue as kind of lined up in nice sheets with one another. Anytime there is any scar tissue, or if there was a surgery or like a resection of anything, when the tissue heals again, it doesn't always lay exactly in the same way as the tissue was before. Sometimes it adds a little bit more of like a jumble of how the tissue is healing there. I will do a lot of scar tissue work and working on fascial mobility at the area of where that is. Sometimes the areas where there is scar tissue can also be painful. And so a lot of that can be that targeted massage, that manual therapy, working through that. We can make some good progress in doing that. I can't always say that it's going to totally go back to how it was in that pre-surgical, but we definitely can make some good leeway in like reducing the sensitivity and helping to address that. Great question.
Okay, thank you.
Hi, good day, everyone. Dr. Emma, I have a quick question.
Yes.
It kind of leans into what Marjorie was just mentioning with scar tissue. So, uh, myself, pelvic floor therapy was not recommended, but I was provided with dilators and general instructions, and I felt like I'm not able to determine if there's any progress being made. I feel like I've been doing it just going on 2 years, and I feel like there hasn't been much improvement. I'm still having pain in the same places. I'm, trying to move from the smaller dilator to the larger dilator. There's still some bleeding, and I'm like, this is after 2 years. So, what would you recommend? Do you think I should ask my GYN to see a pelvic floor therapist, or should my expectations of um some sort of healing? Is it that my expectations are too short, or maybe it takes a longer period of time?
I would ask your OBGYN, do you remember initially why they had suggested that going to physical therapy was not recommended?
No, it just the GYN never mentioned it. As a matter of fact, it was the radiation oncologist who mentioned anything about intimacy, and the nurse in that department is who gave me the dilators. But
Okay.
GYN never had that conversation.
Yeah. I would ask if there was a way that like they have anybody that they would recommend in the area. I'm not sure what state you're all local to, or if like you're able to do direct access for physical therapy, or if you would need a prescription. But I
Mhm.
think like if you are still like you feel like you're doing all of the right things, you're trying the dilators, you're trying to progress, and if it's feeling like you're not really making that progress, personally, like that is the point in which I would want somebody to come in to see me so I can talk about like what exactly is it that you're doing? Like, have you tried things in this way? And maybe they can do a little bit of a deeper dive into what is
Okay.
going on to just help feel like you're heading in the right direction if you haven't been able to really chip away at that progress in the way that you've been wanting to.
Okay. Thank you.
Yeah. Okay. I think we're good for questions. So I'm going to keep going on here. Um, So this piece that I had here is just looking at the actual function of the muscles. So we're thinking of the muscles might become less strong, or on the other end of that, the muscles might become overactive. So this is kind of going back to that balance of the hypertonic versus hypotonic. And sometimes because the change is happening at the level of the tissue, it might be harder to control or sense when we're doing a contraction versus a relaxation versus a bearing down. So the actual level of the function, what I assess is I'm looking at strength, I'm looking at endurance, and I'm looking at coordination. So sometimes that coordination piece is tricky of being like, okay, can I alternate between a contraction versus a relaxation? When I contract, does it feel slow to contract, or maybe does it feel slow to let go when we're going into that relaxation? So we want to be able to fire that contraction, and we want to be able to release and return back to that resting state. So this goes back to that idea of like not all exercises are Kegels. So if somebody has a pelvic floor that is hypertonic and has more muscle tone, if we were to just keep on doing a Kegel exercise and keep contracting, it's probably going to make that tension get a little bit more significant. So likely sometimes I personally like to go for a lengthen before strengthen approach, because if I have my bicep, right, let's say I broke my arm and I was in a cast for so long, and now I can only go from here to here when I'm doing my bicep curl, but I can't extend my elbow past here. I'm not just going to start working on strengthening of this muscle, because if I strengthen, then I'm only going to be able to work in a partial range of motion, versus if I do all of these techniques to free up this muscle, where now I can get that extension. Now, when I go to strengthen, I'm able to go through that full range, and then the function of my arm is going to be better. So that's kind of that idea of being like, I feel like everybody, when they think of pelvic floor, they're like, oh, that's just Kegels, right? And I'm like, partly, yes, there's a time and place for wanting that, but not always. And then again, when we're thinking of any kind of like returning to movement, is how are we going to talk about lifting? What about walking? How are those things that, like, what are the pieces of exercise that you enjoy? A lot of that is what we're also mapping to make sure that you're able to feel confident getting back to that as well. Another change through here is just changes at the level of like total body. So you might be feeling more of that fatigue, might be feeling like your posture is different. Sometimes it's harder to like have that same level of energy that you were having post chemotherapy and radiation. So a lot of it is also that just graded return to exercise or return to existing in a day-to-day life. I'll have conversations with people and they're like, sometimes I go through my whole work day, and even though I'm just sitting there and doing things at the computer, it feels effortful. It feels like my body is doing a lot, which in turn it is. And so we want to start making sure that, yes, we're dialing in on what's happening on the pelvic floor. But again, sometimes it's also essential to zoom out and make sure that we're talking about how are we pacing energy? How can we start to gently progress strengthening? How can we do that strengthening, but not stress at the pelvic floor? And then again, talking about that pressure management, right? So we know we have our diaphragm and our pelvic floor. Is how can we squat? How can we lift? How can we pick things up off the ground without increasing that, where then it's stressing at the pelvic floor, using our breath to our advantage and actually help have more effective exercise. And so then these are some of those other pieces as to like when to seek pelvic floor physical therapy. So if there is pelvic pain that you're still continuing to manage, any changes in bowel and bladder function, if there is pain with intimacy, feeling any changes at the tissue of the pelvis, and then just returning back to those day-to-day life activities. These are all things that I think are very important to make sure that we're discussing and having that open dialogue on. So I'm happy that I was able to bring a little bit more awareness into these pieces. And like in pelvic floor physical therapy, I always love to tell people that like you're definitely going to be starting to talk to somebody and tell people things that maybe not even your closest friends know, but that's also part of like how we know how to help you best, right? Sometimes I'll laugh and I'll say, somebody will be like, oh, like this is TMI. I can't believe I'm talking about my poop right now. But I'm like, well, TMI in my world means tell me immediately, because the more that I know, the more I can help on making sure that we're getting to all those important pieces. So just kind of in summary, again, like thank you for having me and welcoming me into this space to talk about something that's near and dear to my heart and something that I personally find is so essential to those everyday life pieces, right? It's like recovery is not just about the survival, right? It's our quality of life. It's like now we've done all of these pieces of the heavy lifting. Now it's time to make sure that we're allowing you to feel like we can look at this together. And again, I have this on the bottom that it doesn't have to be a piece of navigating this alone, but doing it together and feeling supported to inspire and have you feel encouraged to take that intentional piece of like, how can I do this for myself, and centering yourself in this journey, but also having somebody alongside that's going to cheer you on and help you get there. So that's my piece on there. So I'm happy to answer any other questions and things that might have come up.
Is it ever too late to seek pelvic physical therapy? Are symptoms reversible or just manageable?
It's never too late for that. I think there are always pieces to the puzzle that we can keep addressing. I feel like as you change and as life changes, there's going to be different goals and things that we're going to want to meet. And so with that, I feel like you in accordance with your pelvic floor physical therapist are going to be able to work that together. And I think the other piece of the question was like, are symptoms reversible?
Yeah.
And again, I feel like it also kind of depends on what that might be. But if it is something where maybe it's the pain or changes bowel and bladder, a lot of that is coming down to how the pelvic floor is functioning. And that's a huge role of like what it is that we're training and learning with one another. So will it totally reverse 100%? I feel like sometimes I'm establishing that boundary in the beginning of being like, well, I can't guarantee you're going to be 100% pre chemotherapy radiation as that was. But do I think that we could hopefully make a good dent in learning more about your body? What are these things that are going to be essential to you right now? Are we going to be able to actually change some of those symptoms? Yes. And if we could make at least a good, meaningful, like 75% improvement, I'm happy that that's any improvement. So I think there's really no timeline as to like, is it too late? I always think that the door is always open there.
Thank you so much, Emma, for that presentation. I learned so much information. But if anybody wants to either come off camera or come off mute, feel free to ask any question that you want. I did make a comment, Emma, in the chat when Abina was talking, that I do feel like specifically when it comes to practitioners and specifically Black women experiences, there are often times where we don't even hear about procedures. So I know I'm not off camera, but so and it's often where no one even mentioned it. So they never even said the word pelvic floor therapy as something that might even be an option, even if it's not an option. I think practitioners can say, well, there is this procedure called, pelvic physical therapy, but you're not a candidate for it because of X, Y, and Z. I think when we don't have that information, it kind of makes us feel like we're not being, listened to or trusted or given the best options. So again, I just wanted to thank you for coming on here, and Abina, for even sharing that piece of your story, because you may not have known that this is something you could even ask your GYN about. So I just wanted to talk about that. But again, if anybody has any other questions or comments, feel free. You all have the floor.
Yeah, thank you, Margie, for putting this together, and thank you, Emma, for being here. I do have a question. It's kind of more ECANA centered, related. We have a lot of women in our community who are not here on this call, Emma, but we would love if there's anything that you published or anything that we can present in our either in our June newsletter, which is Uterine Cancer Awareness Month, or even for GCAM, which is Gynecologic Cancer Awareness Month, that we could share with our public on our listserv. Not everybody is always able to be here for Survivor Sanctuary, but we definitely would like to share this information in some meaningful way with those who actually subscribe. And in that case, we can also, because this is very important information. We talk about empowerment, and especially for those actually going through treatment right now, we would want this information to be something they can be armed with. And I would love to be able to, we would love to be able to feature what you have published about empowering yourself with this particular information, and what we should be looking for as far as symptoms of pelvic floor weakness, because like so many of us here, we had not heard of that. We weren't made privy to that as something as a side effect of having even just pelvic radiation, not just even brachytherapy. So we could definitely use this type of expertise to share out. And I think Margie would agree that we would love to have you on again, specifically making sure that we get our larger audiences, even those who haven't gone through endometrial cancer. I think it's still important to know we have people who just deal with incontinence that could benefit from this information as well.
The good news is Margie and we have contact information together. So if it would be useful, I know I kind of like derived a flyer similar on like what we had presented here. I'm happy to send over my slideshow if that's even something you want to email out to everybody, that they can kind of read over from there in addition to the flyer. But I can also kind of write up a summary of all of this if that's something you feel like would be a piece of what you want to like publish in the newsletter. I'm more than happy to do that, and I can send that over to Margie.
That sounds great.
And again, also remember, we will have this presentation. It'll be edited and all that good stuff, but it'll be available on our YouTube website as well. But I definitely agree with Adrienne, like this information would be a wealth of knowledge to our supporters and subscribers that we have. And like she said, a lot of them probably have never even heard pelvic floor therapy, right? We just didn't even know that was something that was available. So yeah, no, absolutely.
Yes, I was grateful that my doctor recognized it, and she said, I think you need to try some lower pelvic therapy. I said, okay. and I was glad I did. I feel like it was maybe 6 or 8 months after my last treatment, but a lot of people hadn't heard of it either, so it became a interest point to just get more knowledge about it and the dilators and all of it. Thank you so much for sharing.
Yeah.
That was great.
And I actually took some notes on the materials you used that you suggested. I think I got it. Somebody, but you're gonna send. Oh yeah, the good clean. What is that?
Oh
That
yeah,
last
yeah, I got it
good
too.
clean
Yeah, I
love,
wrote that down.
restore. Yeah,
Yeah,
yeah.
I wrote it
I
down.
like to reach out to these manufacturers to find out what kind of interest they might have in supporting us in some ways where, we might be able to offer a coupon or something to be able to give out to our survivors. I think this is these are kind of great partnerships we should look toward trying to create just for our overall well-being.
Absolutely, and to get the conversation going. It
Yes.
was a great connect. I appreciate your time and your ease about talking and sharing. I like that. And yes, you guys, please reach out. I will share her contact with you if you just want to talk to her one-on-one too, because it is, it's a delicate situation. I don't talk about it unless somebody brings it up, or I was sharing, like my therapist gave me a list of exercises that everybody can use, not just because you've gone through radiation or chemo or anything, but just for general, just like you were sharing, the general health of our pelvic floor. And it was great. So I shared that information without talking about where I got it or why I knew it. I'm just, guess what I found out? It can be delicate, but we all appreciate it. Any other questions? Are we good? Okay, we're actually ending early. You never
We are.
knew
But
how
Emma,
this
we appreciate you, and
happened.
we hope to have you back. We're going to try to include you in maybe a series that Margie would like to do. Um, you can talk with her, and she can see how we could fit you in for a couple more visits throughout the year.
Great.
Based on a particular topic. That would be great, Margie, to have her again. I think this is a wonderful conversation. And I know there's a lot more that you can share, Dr. Emma, that you probably didn't get a chance to within this time. But if we can graduate, we're ready to graduate.
Yeah.
The only thing I guess we won't be able to, huh?
I was just going to ask Dr. Emma to pronounce her last name.
Oh, Raccaro.
Raccaro. Okay. Notice I never
Yes.
said it, right? Once again, we thank you so much for coming.
Well, thank you for having me. This is great. I get very passionate
It was great.
about
Great.
this. Thank you.
You never
We
know
love
what
your
we're going to get, but
passion. We
that was
appreciate
awesome.
it too.